before I start this presentation, I just like to point out the gentleman to the extreme right, who's the organizing chairman. This was when we had started our residency, and this is like the 10-year challenge. The other girl in the picture will also be coming and taking the hand lecture later. All of us were the students of our professor who's actually chairing this session, Dr. Dhar. So moving on. So osteoporotic burst fractures with incomplete neurology. Like the way sir said, he spoke about the 95% of the patients that we usually see in our clinic. I will be covering the rest 5 which actually require surgery. So this was the original paper by Steele, who had described as to how a Kummal lesion is formed. Usually when the patients come to our clinic, it is roughly 6 weeks, as he said, where we can define an intravertebral non-union and establish that the Kummal is formed. The problem with this non-union, especially when it's at the junction or at one of the lordotic places in the spine, is that there is increasing kyphosis. And if it's a burst component, you will have the retropulse fragment abutting the thecal sac or the cord, causing deficit, which is not immediate, but it appears over a later stage. So you see these guys coming. So you see these guys coming to your clinic with a 2 to 3 by 5, a 3 to 4 by 5, 2 months later after they've sustained that initial trauma. So there are several studies which have shown that the fractured vertebrae, whether you decompress or you don't decompress, the results are.
Vinan, shall you connect our connector? I think that's what the problem is. You have the connector, second connector?
Yeah, let me do.
Yeah, he has come with the second connector. I think we'll give that connector. Is it working?
It's controversial whether to decompress or you don't decompress when these guys come to you with deficit. So what we hypothesized was that what if we coronally and sagittally align these patients, open percutaneously and with augmentation of the index vertebra. I think this was the time when we had won the paper for using fenestrated screws of roughly around 250 of them. When I was training at Calcutta, we just recently won the award for having the best ISJ paper. So what happens when you don't augment? We thought of just splinting these patients and skipping the anterior recon. This is what happens. If there's a race, if the fracture unites or it doesn't, eventually the anterior column will fail and the screws will start backing out, which actually reiterates my point that anterior reconstruction is necessary. Now, doing grotesque reconstruction is something that I would not advise. So there are ways where more than 50% of the collapse you can get away with vertebroplasty, kyphoplasty, index screw fixation and index fenestrated screw with cement augmentation. Now there are different modalities, as we said. So, sometimes we get away with something like this where we had pushed in a dual threaded screw and restored this alignment. You don't have to correct him as if he's an athlete, you just have to restore the alignment to such an extent that will cater to his and her functional outcome. This is where we had used FNSs, which is fenestrated screws with kyphoplasty at the index vertebrae. You can see that the collapse still worsens and there is an increasing kyphosis also every time the patient weight bears. Similar case, but here the modality was different. We just fired in a screw as well, and we pushed cement through the screw. So you have like an FNS modality with an indirect decompression. Now, as we kind of kept on advancing with this, we had this classical collapsibility where I tell all my patients to get a sitting X-ray. This is what happens when you put the patient prone, the fracture completely opens up. And this is the next thing that we thought of, having a biologically superior fixation, which is firing a transpedicular cage through an index vertebra. You pack it with graft like any T-lift cage, and you fire it through one of the pedicles, apart from fixing the fracture. So this was the immediate post-op, the 3 months post-op and the 6 months post-op. Believe you me, these patients come with deficit, 3/5. I'm just coronally and sagittally aligning, giving him the anti-porotic treatment that I have to, and this is what happens. Now she's a walker. At 6 months, I have not disturbed the posterior tension band. I have fired in a cage which has united because it had autograft. This is how it works. This is another gentleman. You see the amount of kyphosis and the collapse. So this is what we did. You see that there is a hollow here, but there is no hollow on the other side. That's because the teriparatide has taken care of it, and you fired a cage from one side which is actually acting as a strut. So this is that gentleman from Jharkhand. This is him, bending forwards, walking. I always get a CT done. Long-term follow-up of these guys really help me for conferences like these to prove my point. This is where you can see that the cage is nicely sat in that index vertebra. On one side, you can see that the entire bone has, covered the cage. On the other side, the bone has united as well. So this is taking care of the intravertebral non-union. Again, this lady, actually she was referred to us by the Tata group of hospitals thinking that it was MET, only to realize that we found that it was an OVCF because we had done a biopsy. Now there is an increasing kyphosis. We fired in a cage. I think this was the last time we had used synthesis screws. I think they stopped working, and this is her at 6 months. So in all, I'm just telling you that the need for augmentation while stabilizing Kummal lesion is a must. Indirect decompression, I think, is a game changer. It preserves the posterior tension band, which a lot of surgeons don't follow. They decompress and then they add to the additional iatrogenic instability by relieving the posterior tension band. Transpedicular cage insertion and bone graft is a good alternative. Whether anterior reconstructions like a big mesh cage and removing those discs and reconstructing anteriorly in these morbid patients is a need or not, I do not know. At the moment, we have 60 cases from Park, Kothari and DY Patil together, talking only about indirect decompression and cement augmentation methods. I think we'll be showcasing them either at MISAPCon or ASICon later this year, and we are soon going to publish this as well. Thank you.
Thank you very much for finishing on time. Thank you.